Welcome to this CPD on working with addiction. This course provides a comprehensive overview of how addiction functions, from its neurological roots to its real-world expression. We'll explore two primary forms of addiction. Chemical addictions, which involve a dependency on a psychoactive substance, such as alcohol, nicotine, or opiates. And behavioral or physical addictions, which involve a compulsion to engage in a specific behavior, such as gambling, gaming, or excessive phone use. While the external triggers are different, a substance versus an activity, the core message of this training is that the underlying neuroscience is fundamentally the same. Both forms of addiction hijack the brain's powerful reward system, creating a cycle of cravings, tolerance, and withdrawal. Understanding this shared structure is key to recognizing and effectively treating addiction in all its forms.
Hello and welcome. My name is John Lowson, and I'm an experienced clinical hypnotherapist, solution-focused psychotherapist, a hypnotherapy supervisor, and a lead trainer for both the NCH and the APHP. I will be delivering this CPD today, and I'm glad you've joined me for this important training. Upon completion of this video and the accompanying assessment quiz designed to reinforce the key learning points, you will be awarded 2 hours of CPD.
Why addiction work is different.
As we kick off this CPD, I want to first talk about a crucial aspect of working with addiction and dependency, something that goes beyond the techniques you learned to get your diploma. Confidence. Let's be frank, the kind of deep, resilient confidence required to effectively handle addiction cases is not something that can be fully taught in a training school. Training schools do an excellent job of teaching us the how-to, the inductions, the suggestion patterns, the parts therapy, and the solution-focused questioning. They give us the tools. However, they cannot adequately prepare you for the dynamic and often chaotic reality of sitting with a client in the grip of a powerful addiction. Think of it like learning to drive. The instructor teaches you how to operate the car, the clutch, the gears, the mirror checks, but that doesn't prepare you for the visceral, split-second decision-making required when you're on a fast-moving motorway in torrential rain with lorries on either side. That requires a different level of confidence, one born from understanding the underlying dynamics at play.
Why confidence is your most important tool.
When working with addiction, your confidence is not just a personal attribute, it is an essential part of the therapeutic container. Here's why. You must be the unshakable anchor. Clients struggling with addiction often live in a state of chaos and emotional turmoil. Their lives can be unstable and unpredictable. They don't need a therapist who is easily rattled or shocked. They need an anchor, your calm, unwavering confidence that recovery is possible even in the face of a relapse or crisis provides the stability they need to feel safe enough to change. Navigating crisis and relapse. A client might call you in a panic, having just relapsed. A textbook can't teach you how to handle that moment. An unconfident therapist might see it as a failure, theirs or the client's. A confident practitioner sees it as part of the process, a data point to be understood and worked with. Your confidence allows you to hold the frame, manage the crisis without panic, and guide the client back to the path of recovery. Working with deep ambivalence. Addiction is defined by ambivalence, the simultaneous desire to stop and the intense compulsion to continue. An unconfident therapist can get drawn into a power struggle, trying to convince the client to change. A confident, solution-focused therapist understands this is normal. You can comfortably sit with that ambivalence, using your skills to explore the part of them that does want change, thereby strengthening their own intrinsic motivation without a fight. This CPD is designed to help you build that specific, robust confidence by understanding the underlying neuroscience, how the limbic system, the PFC, and the RAS are all at play. You'll move beyond simply applying techniques. You'll gain a deeper insight that allows you to remain centered, creative, and effective, even when faced with the most challenging of clients. You will learn to trust yourself, your skills, and your client's innate ability to find their own solution. Your learning outcomes from this CPD will be: 1. You will be able to differentiate between chemical and behavioral addictions and explain the shared underlying neuroscience, specifically how both types hijack the brain's powerful reward system, leading to a cycle of cravings, tolerance, and withdrawal. 2. You will be able to identify the key brain structures of the mesolimbic reward pathway, VTA, amygdala, nucleus accumbens, prefrontal cortex, and describe their specific roles within the three-stage cycle of addiction: the high, the crash, and the craving. 3. You will be able to classify major psychoactive substances into the categories of depressants, stimulants, and hallucinogens. You will also be able to summarize their primary effects, distinct mechanisms of action, and potential for dependence. 4. You will be able to apply solution-focused brief therapy, SFBT, techniques such as the miracle question and searching for exceptions. You will also be able to articulate how these methods are designed to engage the client's prefrontal cortex, intellectual brain, and recalibrate the reticular activating system, RAS, to focus on solutions rather than problems. 5. You will be able to describe how to integrate clinical hypnotherapy with conscious therapy work by using techniques like future pacing and anchoring. The objective is to align the client's subconscious programming with their consciously defined recovery goals, creating a unified neurological purpose. 6. You will be able to identify key professional and ethical responsibilities, including establishing firm boundaries, understanding the limits of confidentiality for safeguarding, and the critical importance of advising clients to seek medical consultation for safe cessation, especially from alcohol and benzodiazepines. So let's dive in.
Introduction to psychoactive drugs.
Consciousness can be defined as an individual's awareness of themselves and their environment. Certain chemicals, known as psychoactive drugs, can alter this state of consciousness by affecting perceptions and moods. Psychoactive drugs are broadly classified into three main categories: depressants, stimulants, and hallucinogens. This section will focus on depressants and a related class called opiates.
Depressants.
Depressants are drugs that lower the body's basic functions and neural activity. This includes reducing heart rate, slowing reaction times, and decreasing cognitive processing speed. Firstly, let's look at alcohol. Alcohol is the most common depressant and significantly alters consciousness. In terms of neural processing, it slows the central nervous system, including the sympathetic nervous system, impairing reaction time and cognitive function. When we look at sleep disruption, it disrupts the regular sleep cycle, particularly REM sleep. A lack of REM sleep can reduce the ability to form new memories and synapses. And regarding disinhibition, it removes inhibitions, leading to impulsive behavior, impaired judgment, and reduced self-control. Next, we look at barbiturates. Formerly known as tranquilizers, barbiturates are clinically used to induce sleep or reduce anxiety. Their mechanism of action is that they work by depressing central nervous system activity. Side effects can include reduced memory, judgment, and concentration. A critical warning: combining barbiturates with alcohol is extremely dangerous and can be fatal. And then we have benzodiazepines, or benzos. Benzodiazepines are the most commonly prescribed class of depressant drugs, often used as sleep aids or for anti-anxiety treatment. They're also known as downers. Their mechanism of action is that they enhance the brain's response to the inhibitory neurotransmitter GABA, gamma-aminobutyric acid. Benzodiazepines open GABA-activated chloride channels in neurons. This allows more chloride ions to enter the neuron, making it more negatively charged and thus more resistant to excitation. Regarding types and uses, short and intermediate acting are typically prescribed for insomnia. Long acting are preferred for managing anxiety.
Opiates.
Opiates are primarily used to treat pain and can also be prescribed for anxiety. Common examples include morphine and heroin. The mechanism of action for opiates is that they act on the body's endorphin receptor sites. Endorphins are the body's natural pain-reducing neurotransmitters. High doses can lead to a state of euphoria, which contributes to their potential for recreational use. Their distinction from depressants is that although their applications can overlap, for example, anxiety reduction, their mechanisms are distinct. Depressants act on GABA receptors, whereas opiates act on endorphin receptors.
Key takeaways and clinical considerations.
It is crucial to distinguish between the mechanisms of depressants, GABA receptors, and opiates, endorphin receptors. Combining psychoactive substances, particularly any depressant with alcohol, significantly increases the risk of severe adverse effects, including death. The body has a limited capacity to metabolize multiple foreign substances. All the drugs discussed carry a high potential for addiction. Therefore, extreme caution must be exercised with sleep aids or any psychoactive substance.
Depressant drugs and their effects.
The following table provides more detail. For the drug class alcohol or ethanol, slang names include booze, liquor, spirits, vino, and meths. Common effects include initial feelings of relaxation and euphoria, reduced social inhibition, impaired coordination, judgment and reaction time, slurred speech, drowsiness, and memory loss. High doses can lead to respiratory depression, coma, or death. For barbiturates like phenobarbital, slang names include barbs, downers, sleepers, yellow jackets, and reds. Common effects include strong sedation and induction of sleep, anxiety reduction and muscle relaxation, feelings of euphoria or contentment, confusion, impaired memory, and poor judgment. There is a very high risk of overdose and severe respiratory depression. For benzodiazepines, like diazepam and alprazolam, slang names include benzos, downers, tranks, nerve pills, Xans for alprazolam, and Valium for diazepam. Common effects include reduction of anxiety and panic, sedation, muscle relaxation, and drowsiness, amnestic effects or memory loss, dizziness, confusion, and depression. There is a high potential for physical dependence and addiction. For opioids, like heroin, morphine, fentanyl, and oxycodone, slang names include H, smack, and junk for heroin, oxy and perks for oxycodone, and fenty for fentanyl. Common effects include intense euphoria and pain relief, analgesia, drowsiness and a heavy feeling in the limbs, nodding off, mental confusion and nausea, and severely slowed breathing, respiratory depression, which can be fatal. There is an extremely high potential for addiction. For GHB or gamma hydroxybutyrate, slang names include G, liquid ecstasy, liquid X, and Georgia homeboy. Common effects include feelings of euphoria, relaxation, and increased sociability, drowsiness, dizziness, and nausea, memory loss and loss of consciousness. The dose for desired effects is very close to the overdose dose. For sleep medications like zolpidem and isoprolol, slang names include Z-drugs and zombie pills. Common effects include it induces sleep and sedation, can cause complex sleep-related behaviors like sleepwalking or sleep driving, and can cause dizziness, headache, and a drugged feeling the next day.
Stimulants.
This next section provides an overview of stimulant drugs, which intensify neural activity and bodily functions, contrasting them with depressants. What are stimulants? Stimulants are a class of psychoactive drugs that stimulate or intensify neural activity and bodily functions. This is the opposite effect of depressants, which slow down these processes. The category includes everything from everyday substances like caffeine to powerful illegal drugs like cocaine and methamphetamines. Here are some commonly used stimulants, which I'm sure you are familiar with. Caffeine. Caffeine is a widely consumed stimulant that increases energy and can disrupt sleep for several hours. The body can become physiologically addicted, leading to withdrawal symptoms if consumption stops. Withdrawal symptoms include headaches, irritability, difficulty concentrating, and depression. Nicotine. Found in tobacco products, nicotine has effects similar to caffeine but is significantly more addictive. Its primary effects are that it increases heart rate, raises blood pressure, suppresses appetite, and enhances alertness. Withdrawal symptoms include anxiety, insomnia, distractibility, and irritability. Weight gain upon quitting smoking is common as the appetite-suppressing effect of nicotine is removed. Let's look at some potent and illicit stimulants. Cocaine. Now, cocaine is a powerful stimulant that forces the brain to release a massive amount of dopamine, serotonin, and norepinephrine. The crash occurs because this depletes the brain's natural supply of these neurotransmitters, leading to an intense depressive crash when the drug wears off. Long-term risks of regular use can cause emotional disturbances, suspicion, convulsions, cardiac arrest, and respiratory failure. Amphetamines and methamphetamines. Like cocaine, these drugs trigger the release of dopamine. Methamphetamine, or meth, is particularly potent and highly addictive. Its effects include causing a long-lasting euphoric high of up to 8 hours, followed by intense irritability, insomnia, seizures, and depression. Regarding addiction and long-term damage, addiction can be all-consuming. Long-term use may permanently damage the brain's ability to maintain normal dopamine levels as it attempts to adapt to the extreme highs.
Stimulant drugs and their effects.
The following table provides more detail. For the drug class caffeine, types include coffee, java, tea, and energy drinks. Common effects include increased alertness and wakefulness, improved attention and focus, and can cause jitteriness, anxiety, insomnia, and an increased heart rate. For nicotine, types include cigarettes, also known as smokes or cigs, vapes, and chewing tobacco. Common effects include a temporary increase in alertness and heart rate. It can have both stimulant and relaxing effects and is highly addictive. It can cause increased blood pressure and constrict blood vessels. For cocaine, slang names include coke, blow, snow, and crack for the smokable form. Common effects include intense, short-lived euphoria and energy, increased mental alertness and talkativeness, decreased appetite and need for sleep. It can cause paranoia, irritability, and severe cardiovascular strain. A crash of depression and fatigue often follows. For amphetamines, such as Adderall and Dexedrine, slang names include speed, uppers, amps, and study drugs. Common effects include increased focus, wakefulness, and productivity, suppressed appetite, feelings of euphoria and self-confidence. It can lead to nervousness, insomnia, paranoia, and a high potential for psychological dependence. For methamphetamine, slang names include meth, crystal, ice, crank, and glass. Common effects include a powerful and long-lasting rush of euphoria, significantly increased energy, activity, and talkativeness. Severe effects include anxiety, confusion, hallucinations, and paranoia. It is extremely addictive with significant long-term health consequences, including severe dental problems and brain damage. For MDMA, or methylene-deoxymethamphetamine, slang names include ecstasy, Molly, E, and X. Common effects include it acts as both a stimulant and a mild hallucinogen, causes heightened sensations, emotional warmth, and empathy, and increases energy and decreases the need for sleep. It can cause dehydration, dangerously high body temperature, or hypothermia, and confusion.
An introduction to hallucinogens.
Hallucinogens are a class of psychoactive drugs that cause users to experience hallucinations, sensations, and perceptions that are not real. While they all alter perception, different types have a wide range of physiological effects, and some even have medical applications. Here are some specific types of hallucinogens. Ecstasy, or MDMA. Ecstasy is a synthetic drug that functions as both a stimulant and a hallucinogen. Its stimulant effects include significantly increasing dopamine and serotonin, leading to euphoria. It also stimulates the central nervous system, causing high blood pressure, dehydration, and overheating, which can be fatal. Long-term use can permanently damage serotonin-producing neurons, potentially leading to a chronically depressed mood. Its hallucinogenic effects cause hallucinations and heightened sensations, often creating an artificial feeling of social connectedness and intimacy. LSD, or lysergic acid diethylamide. LSD is considered the prototypical hallucinogen. Its mechanism of action is that it interferes with serotonin transmission in the brain. Its primary effects are that it primarily causes visual hallucinations, making users see things that are not there, marijuana or cannabis. Marijuana is a mild hallucinogen that also shares properties with depressants. Its hallucinogenic effects are that its main active ingredient, THC or tetrahydrocannabinol, heightens sensitivity to colors, sounds, tastes, and smells. Its depressant-like effects mean that, like alcohol, it reduces inhibitions, impairs motor coordination, and relaxes the CNS. It can also disrupt memory formation and short-term recall. A unique property of marijuana is that, unlike many drugs, THC can stay in the body for up to a week. This means regular users may require less of the drug over time to achieve the same effect. Medical uses of hallucinogens. Hallucinogens are being explored for various medical applications. For pain and nausea relief, marijuana is sometimes used in medical settings to alleviate pain and nausea, though its side effects must be weighed against its benefits. For PTSD treatment, certain hallucinogens may help individuals with PTSD access painful memories in a detached way without the strong emotional reaction. This can allow them to process and come to terms with trauma in a way that might not be possible otherwise.
Hallucinogenic drugs and their effects.
The following table provides more detail. For the drug class LSD or lysergic acid diethylamide, slang names include acid, tabs, lucy, and doses. Common effects include profound alterations in perception, thought, and mood, intense visual hallucinations, for example, geometric patterns, trails, and intense colors, an altered sense of time and spiritual experiences. A bad trip can involve terrifying thoughts, paranoia, and feelings of despair. For psilocybin, slang names include magic mushrooms, shrooms, and mushies. Common effects include it causes euphoria, spiritual experiences, and a sense of connection to nature. Visual and auditory hallucinations, altered perception of reality. Effects are highly dependent on the user's mindset and environment, known as set and setting. It can cause nausea, anxiety, and paranoia. For DMT or dimethyltryptamine, slang names include Dimitri and the spirit molecule. Common effects include a very powerful, intense, and short-acting hallucinogen. It is often described as producing a feeling of entering a different reality or dimension. It causes complex visual and auditory hallucinations and encounters with entities. For mescaline from the peyote cactus, slang names include buttons, cactus, and peyote. Common effects include similar effects to LSD, including altered consciousness and visual hallucinations. It is often used in a spiritual or ceremonial context. It can cause significant nausea, vomiting, and anxiety before the main effects begin. For PCP or phencyclidine, slang names include angel dust, hog, and rocket fuel. Common effects include it is a dissociative drug causing detachment from reality. It causes feelings of invulnerability, strength, and numbness. It can cause hallucinations, slurred speech, and loss of coordination. It is known for causing unpredictable, aggressive, or violent behavior and psychosis. For ketamine, slang names include K, Special K, Kit Kat, and Cat Valium. Common effects include it is a dissociative anesthetic that causes a trance-like state. It causes a feeling of detachment from one's body and environment and impaired motor function. High doses can induce a K-hole, an intense out-of-body experience. Long-term use is associated with severe bladder damage.
Homeostasis, tolerance, and overdose.
What is homeostasis? Homeostasis is the process by which your brain and body work to maintain a stable internal environment. This includes regulating core functions like body temperature, heart rate, and metabolism, despite changes in external conditions. When your body is pushed out of balance, for example, by exercise making you hot and increasing your heart rate, homeostasis works to return you to your normal state. This same principle applies when drugs are introduced into the system. Let's talk about homeostasis and drug tolerance. The body is remarkably adaptive. When a person uses drugs regularly, the brain learns to anticipate the drug's effects and prepares the body in advance. This is called the anticipatory response. If a drug like an amphetamine, which raises the heart rate, is taken repeatedly in the same context, for example, a specific room with certain equipment at a particular time, the brain associates these external cues with the impending arrival of the drug. This leads to a pre-adjustment. After several repetitions, the brain will initiate a counter response before the drug is even taken. In anticipation of the stimulant, it will start to lower the heart rate and metabolism to get a head start on maintaining homeostasis. This is what builds tolerance. Because the body has already started counteracting the drug's effects, a person needs to take a higher dose to achieve the same high they initially experienced. This is the basis of drug tolerance. Let's consider the conditioned crash and overdose risk. This learned homeostatic response explains two critical phenomena in drug use: withdrawal and overdose. The crash, which is cues without the drug. What happens if the body is exposed to all the familiar cues, but the person doesn't take the drug? The brain initiates its pre-adjustment, lowering the heart rate and metabolism in anticipation. Without the drug to counteract this preparatory slowing, the person experiences a crash or withdrawal-like symptoms, as their body is in a state primed for a drug that never arrives. Overdose risk, which is the drug without the cues. What happens if the person takes their usual high dose, but in a new and unfamiliar location? The brain does not receive the external cues it has learned to associate with the drug, so it does not pre-adjust the body. The person takes their usual high dose, which their body has developed a tolerance for only in the familiar setting. Without the preparatory homeostatic response, the full unmitigated effect of the high dose hits the unprepared system. This is a common reason for accidental overdose.
Key takeaways.
Homeostasis is the body's natural drive to maintain internal stability. Tolerance develops as the brain learns to anticipate a drug's effects based on environmental cues and launches a counter-response in advance. Encountering drug-related cues without taking the drug can trigger a crash. Taking a customary high dose in a new environment is extremely dangerous and can lead to overdose, as the body's learned tolerance is cue-dependent and will not be activated.
An overview of drug routes of entry.
Number 1, oral administration. This is one of the most common and slowest routes of entry. The method is that the drug is swallowed in the form of a pill, liquid, or other edible and absorbed through the gastrointestinal tract. The speed is slow, typically taking around 30 minutes for the drug to be absorbed into the bloodstream and for effects to begin. Examples include taking a pill or drinking alcohol. Number 2, inhalation. This method provides a much faster onset of effects compared to oral administration. The method is that the drug is breathed in, snorted, or smoked, allowing it to pass quickly from the lungs into the bloodstream and then to the brain. The speed is very fast, with effects often felt within 10 seconds. Examples include smoking tobacco or snorting cocaine. Number 3, intravenous or IV injection. This is the most direct and one of the fastest routes of administration. The method is that the drug is injected directly into a blood vein. The speed is almost instant, within seconds. The risks are significant. Using unsterilized paraphernalia can introduce bacteria, toxins, and blood-borne viruses like HIV directly into the bloodstream. Number 4, transdermal administration. This method involves absorption through the skin and provides a slow, steady release. The method is that a drug is contained within a patch applied to the skin and is absorbed gradually. The drug must be potent to be effective via this route. The speed is very slow, designed to release the drug into the bloodstream over several hours. An example is a nicotine patch. Number 5, intramuscular or IM injection. This method involves injecting a drug directly into muscle tissue. The method is that a needle is used to administer the drug into a large muscle, such as in the thigh or arm. The speed of absorption can be either very fast or gradual, depending on the drug's chemical properties and the blood supply to the muscle. Examples of fast-acting injections include an EpiPen delivering epinephrine into the thigh muscle during a severe allergic reaction. Examples of gradual-acting injections include many vaccines, such as the flu shot, which can cause muscle soreness at the injection site.
Key takeaway: speed and dependence.
There is a direct correlation between a drug's rate of absorption and its potential to cause dependence. The faster a drug takes effect, the higher its addictive potential. For instance, drugs that are injected, fast-acting, are more likely to lead to dependence than drugs that are taken orally as pills, slow-acting.
Understanding behavioral addictions.
Behavioral addictions, also known as process addictions, involve a compulsion to engage in a rewarding non-substance related behavior despite negative consequences. While no chemical substance is consumed, the neurological and psychological patterns are strikingly similar to those of substance use disorders. Common examples include gambling, gaming, shopping, and excessive phone or internet use.
The neurobiology, the brain on behavior.
The root of behavioral addiction lies in the brain's reward system, the same pathway hijacked by psychoactive drugs. Regarding dopamine release, engaging in the behavior, for example, winning a bet or getting a like on social media, triggers a release of dopamine in the brain's reward pathway. This creates a powerful feeling of pleasure and reinforces the behavior, making the brain want to repeat it. Regarding tolerance and cravings, over time, the brain adapts to this constant overstimulation by reducing its number of dopamine receptors. This is tolerance. The individual now needs to engage in the behavior more frequently or intensely, for example, making bigger bets or scrolling for longer to achieve the same euphoric feeling. This diminished response also leads to powerful cravings when not engaged in the behavior. Regarding withdrawal, when the person tries to stop, they experience emotional and psychological withdrawal symptoms. These are not typically life-threatening like some substance withdrawals, but they are highly distressing and include irritability, anxiety, depression, restlessness, and an inability to concentrate. The person often returns to the behavior simply to find relief from these feelings. Common examples: gambling disorder. Gambling is the most formally recognized behavioral addiction. It is characterized by a persistent and recurrent pattern of problematic gambling behavior leading to significant impairment or distress. A key feature is the chase. After losing money, the individual often returns the next day to try and win it back, a pattern that typically leads to even greater financial losses. The intermittent and unpredictable nature of rewards makes it exceptionally reinforcing. Problematic internet or phone use. While not yet a formal diagnosis in the same way as gambling, problematic phone and internet use is a growing concern. This includes compulsive social media scrolling, online shopping, and gaming. A key feature is variable reward schedules. Platforms like social media are designed to be addictive. The unpredictable nature of notifications, likes, and new content creates a dopamine loop that keeps the user constantly checking their device for the next small reward, often leading to a loss of time and neglect of real-world responsibilities.
The brain's reward pathway and addiction.
Let's look at an overview of the reward pathway. When you experience something pleasurable, like eating good food, receiving praise, or taking certain drugs, your brain activates a specific network known as the reward pathway. This system is designed to reinforce behaviors that are beneficial for survival. The primary neurotransmitter involved is dopamine. When you encounter a rewarding stimulus, your brain releases dopamine, which creates a feeling of pleasure and motivates you to repeat the behavior. Let's take a look now a little deeper at the key structures in the reward pathway. The reward pathway involves several interconnected brain regions, primarily originating from the ventral tegmental area, or VTA, in the midbrain, which is the main dopamine-producing center. The ventral tegmental area, or VTA, produces and releases dopamine when it detects a rewarding stimulus. The amygdala processes emotions. When it receives dopamine, it registers the experience as pleasurable and enjoyable. The hippocampus is responsible for forming memories. It records the context of the rewarding experience, where you were, who you were with, what you were doing, to help you repeat it. The nucleus accumbens controls motor functions. It prompts you to take action to continue the pleasurable experience. For example, take another bite of cake. The prefrontal cortex manages attention and planning. It helps you focus on the rewarding stimulus. Collectively, the pathway connecting these structures, the amygdala, hippocampus, and nucleus accumbens, is often referred to as the mesolimbic pathway. Now let's explore how the pathway creates a loop. Let's use the example of eating a delicious piece of cake. You take a bite. The VTA releases dopamine. The amygdala says, "This is amazing. I feel happy." The hippocampus notes, "I'm at this cafe eating this specific chocolate cake. I need to remember this." The nucleus accumbens prompts, "Let me use my fork to get another bite." The prefrontal cortex focuses your attention on the cake. This creates a powerful, self-reinforcing loop that makes you want to continue the behavior. Now let's look at our old friend serotonin and its role in addiction. As dopamine levels rise during a rewarding experience, levels of another neurotransmitter, serotonin, tend to fall. Serotonin is linked to feelings of satiation or contentment. This imbalance, high pleasure from dopamine but low contentment from serotonin, can drive a compulsive need to seek more of the reward, which is a key factor in addiction. So you can see that addiction is biological. It's now understood that addiction is not simply a moral failure, but has a strong physiological component. Drugs, especially stimulants, can hijack the reward pathway, causing an intense dopamine release that is far greater than natural rewards. Animal studies provide strong evidence for this. Rats will quickly learn to press a lever to receive cocaine, even engaging in drug-seeking behaviors and increasing their dose. An addicted brain responds differently to negative consequences. While a rat will learn to avoid food that makes it sick, a drug-addicted rat will continue to seek the drug even when it's paired with a substance that makes it sick. This shows how addiction can override the rational mind, making the drive for the reward all-consuming.
The addiction cycle.
Understanding the cycle of addiction is crucial for any professional working with clients in this field. Moving beyond a purely behavioral model, this section links the observable stages of addiction to the underlying neurobiology of the brain's reward pathway. By grasping how substances hijack these fundamental neural circuits, practitioners can approach clients with greater empathy, develop more effective interventions, and better explain the profound difficulty of breaking the cycle. This framework helps reframe addiction not as a moral failing, but as a chronic brain disorder. The cycle consists of 3 stages. 1, the high. 2, the crash. And 3, the craving. Stage 1, the binge or intoxication phase, the high. This is the stage where the client actively uses the substance and experiences its pleasurable effects. What's happening in the brain? The substance causes the ventral tegmental area, or VTA, to release a massive, overwhelming flood of the neurotransmitter dopamine into the brain's reward circuit, also known as the mesolimbic pathway. This surge is far more intense than what the brain experiences from natural rewards like food or social interaction. The amygdala registers this experience as intensely pleasurable, creating a powerful emotional memory. The hippocampus works to form lasting memories of this rewarding experience, linking the feeling to the environment, the people, and the paraphernalia involved, which become triggers. It essentially says, "Remember everything about this so we can do it again." The nucleus accumbens receives the dopamine signal and reinforces the motor functions associated with use, the act of drinking, injecting, or smoking. It drives the action. The prefrontal cortex, which governs focus and planning, is overwhelmed, leading to a narrowing of attention solely onto the rewarding experience. Stage 2, the withdrawal or negative effect phase, the crash. This stage begins as the substance wears off. The client experiences unpleasant physical and emotional symptoms, creating a strong motivation to use again simply to alleviate the discomfort. What's happening in the brain? The intense dopamine stimulation from the binge phase causes a significant neurochemical imbalance. The brain, attempting to regain stability, drastically reduces its own dopamine production and sensitivity. The result is a dopamine deficit where levels crash far below the normal baseline. This leads to feelings of depression, anhedonia, the inability to feel pleasure, and fatigue. Simultaneously, as noted in the reward pathway model, levels of serotonin, a neurotransmitter linked to feelings of satisfaction and contentment, are also depleted. This combination of low dopamine and low serotonin creates a state of profound dysphoria and unease. The brain is now in a state of distress, perceiving the absence of the drug as a threat and signaling that it needs the substance just to feel normal again. Stage 3, the preoccupation or anticipation phase, the craving. In this stage, the client is consumed by thoughts of using the substance again. This is where the cycle becomes deeply entrenched. What's happening in the brain? The brain is now primed to seek the drug. Environmental cues, seeing a pub, receiving a stressful email, or even a particular time of day, trigger the powerful memories stored by the hippocampus and amygdala. These triggers activate the reward circuit in anticipation of the drug, creating an intense craving. The prefrontal cortex is now compromised. Its executive functions, rational thought, impulse control, and long-term planning are hijacked by the overwhelming drive from the reward circuit. Instead of weighing the negative consequences, its primary function becomes planning how to obtain and use the substance again. This is the neurobiological basis for what appears to be a rational mind being taken over. This obsessive thought process drives the drug-seeking behavior, leading the client back to stage 1, often with an increased intensity that further strengthens these neural pathways. The cycle repeats, becoming faster and more powerful over time.
Tolerance, dependence, and withdrawal.
Tolerance, needing more for the same effect. Tolerance is when your body gets used to a drug, requiring you to take more of it to achieve the same effect you once did with a smaller dose. So what happens at the neuron level? The brain's reward circuit functions via neurons releasing neurotransmitters like dopamine into a synapse where they bind to receptors on the next neuron. When overstimulated, such as when drugs like cocaine are used, they flood the synapse with an abnormally high amount of dopamine, constantly stimulating the postsynaptic neurons. The brain's response is to perceive this as being too much. To maintain balance, homeostasis, it tries to dampen the signal. This is called receptor downregulation. The brain reduces the number of available dopamine receptors on its neurons. With fewer receptors, the same amount of dopamine can't produce the same intense high. This is the neurological basis of tolerance. Dependence, the physical and emotional need. As tolerance builds, a person often develops a dependence on the drug. This means the body and mind have adapted to the drug's presence and now require it to function at a baseline level. Physical dependence is when the body experiences negative physical symptoms, withdrawal, without the drug. Emotional dependence is when a person feels a psychological need or craving for the drug. This dependence, combined with tolerance, creates a dangerous cycle. To overcome the brain's new dampened response, the user must take a progressively higher dosage to feel the desired effect. Withdrawal, the body's reaction to absence. Withdrawal occurs when a person who is dependent on a drug stops taking it. The body, now accustomed to high levels of dopamine from an external source, has often reduced its own natural production. Symptoms and causes. Without the drug, dopamine levels plummet far below normal. The user is no longer seeking euphoria. They are trying to escape the negative state of withdrawal and simply feel normal again. Common withdrawal symptoms include depression, anxiety, headaches, and sweating. This intensely unpleasant state is a powerful motivator to continue using the drug, which is a hallmark of addiction. Recovery is possible. The good news is that the brain is adaptable. Just as it can get used to the presence of a drug, it can also get used to its absence. With time and effort, the brain's reward system can begin to regulate itself again and function more normally, even if other long-term damage has occurred.
Understanding substance-related disorders.
Key concepts in substance use. When discussing drugs, more formally called substances, it's important to understand the core processes involved when they interact with the human body. Intoxication. This refers to the behavioral and psychological effects a substance has on a person as it enters and acts upon their body. The effects are specific to the drug being used. Examples: being drunk from alcohol or high from cocaine are colloquial terms for intoxication. Withdrawal. This occurs when someone stops taking a substance after a prolonged period of use. The body reacts to the absence of the drug, leading to withdrawal symptoms that can range from making a person feel sick to being life-threatening. For example, alcohol withdrawal can cause seizures and be fatal. Types of substance-related disorders. It's crucial to distinguish between two main categories of disorders related to substance use. Number 1. Substance-induced disorders. These are conditions directly caused by the substance itself. The substance can induce other mental health conditions, such as mood disorders like mania or depression, anxiety disorders, problems with sleep or sexual function, and psychosis, which is a loss of contact with reality involving hallucinations or paranoia. Number 2, substance use disorders. This is a separate diagnosis that occurs when a person's pattern of substance use causes significant impairment in their life. Not everyone who uses a substance develops this disorder. The core issue is that the way they use the substance is problematic and negatively affects their functioning at work, school, or home. Diagnosing a substance use disorder. A substance use disorder is identified by looking for 3 key indicators: problematic use, withdrawal, and tolerance. The presence of just 2 or more criteria can be enough for a diagnosis. Problematic use. This involves a pattern of behavior where the substance use is clearly causing problems. Key signs include using increasingly large amounts of the substance, experiencing strong cravings or desires to use, spending excessive time obtaining, using, or recovering from the substance, failing in attempts to cut down or control use, and neglecting major obligations at work, school, or home due to use. Withdrawal. The presence of withdrawal symptoms upon cessation is a strong indicator of a substance use disorder. It suggests a physiological dependence, meaning the person's body has adapted to the presence of the drug and now needs it to function normally. Tolerance. Tolerance is when the body adapts to a drug, so the effect of a given dose decreases over time. To achieve the same level of intoxication, the person must continually increase the amount of the substance they use. Note on severity. Substance use disorders exist on a spectrum from mild to moderate to severe based on the number of criteria met. Exception for caffeine. According to current diagnostic criteria, caffeine is the one common substance for which a substance use disorder cannot be formally diagnosed.
An overview of drug addiction treatments.
Effective treatment addresses both the physiological and psychological aspects of addiction. Detoxification is the initial period of medically supervised withdrawal to safely manage symptoms and flush the substance from the body. Pharmacological treatments or medication include: for opiates, methadone activates opioid receptors slowly, reducing cravings and dampening the high. For nicotine, there is nicotine replacement in the form of patches or lozenges or medications that block the dopamine reward signal. For alcohol, there are medications that block the rewarding effects of drinking and ease withdrawal symptoms. Psychological and behavioral treatments include: cognitive behavioral therapy, or CBT, helps patients recognize problematic thought patterns, develop coping strategies, and anticipate high-risk situations to prevent relapse. Solution-focused brief therapy, or SFBT, is a short-term, goal-oriented therapy that focuses on a person's strengths and solutions rather than their problems and deficits. Instead of analyzing the past causes of addiction, SFBT helps clients envision a preferred future without substance use and identify the skills and resources they already possess to achieve it. The therapist asks questions like, what would your life look like if this problem was solved? To build motivation and create concrete, actionable steps toward recovery. Clinical hypnosis is a therapeutic technique where a trained clinician guides a person into a state of deep relaxation and focused attention. In this state, the person is more open to suggestion. For addiction, Hypnosis can be used to reduce cravings by associating substance use with negative feelings, strengthen coping skills for managing triggers, and address underlying issues like anxiety or trauma that may contribute to substance use. It is a complementary therapy, often used alongside other treatments like CBT. Group meetings like 12-step programs such as AA and NA provide peer support through a structured process of acceptance, surrender, and active involvement. Relapse prevention. Relapse is a common part of recovery, often triggered by environmental cues. Treatment focuses on developing skills to anticipate and manage these triggers to maintain long-term recovery.
Solution-focused psychotherapy, or SFBT.
As a solution-focused therapist, the approach remains focused on building a hopeful, compelling future. You can deepen this process by understanding the neuroscience that makes it so effective, particularly how we can train the brain to notice opportunities for change. Step 1. Co-constructing the preferred future and engaging the intellectual brain. The initial sessions are designed to bypass the problem-focused parts of the brain and activate the centers of planning and possibility. Establishing a collaborative stance is the first step to establish a partnership. SFBT sees the client as the expert in their own life, full of resources they may not yet recognize. Our role is to ask questions that will help them discover their own solutions, asking the miracle question instead of focusing on the problem, which keeps the emotional reactive limbic system in charge. We ask a question to engage their creative, thoughtful, intellectual brain, the prefrontal cortex, or PFC. We ask, suppose at some point from now, an unknown miracle has occurred. The miracle is that the addiction problem that brought you here is solved. When you wake up tomorrow, what is the very first small thing you will notice that tells you this miracle has occurred? As we vividly detail this future, what they'd be doing, who would notice, how they'd feel, we are creating a new, compelling neural blueprint. This conversation activates the anterior cingulate cortex, or ACC, the brain's novelty detector. The ACC recognizes these hopeful new ideas as important and flags them, passing this novel information up to the PFC for conscious consideration. Step 2. Discovering exceptions to recalibrate your brain's filter. The brain has a filter called the reticular activating system, RAS or RAS, which directs your attention to what it believes is important. When we're focused on a problem, the RAS is programmed to constantly scan for evidence of that problem. Our goal is to retrain it, searching for exceptions. We actively look for times when the problem has less influence. We ask, tell me about a time in the past week when the urge was there, but you did something else instead, even for a few minutes. And what was happening on a day that was even 5% better than the worst day? When we identify an exception, our ACC again fires, flagging this as novel and important information. This is a moment of success. Pay attention. This positive data is sent to the PFC. We also use scaling questions to make progress tangible and highlight the client's agency. We may ask, on a scale of 0 to 10, where 10 is the miracle day, where are you right now? If the client says a 3, my crucial follow-up would be, that's great. What have you already done to get yourself to a 3 and not a 0 or a 1? This question forces the client's PFC to search for evidence of their own success, builds on past resources, and reinforces the idea that they have control. Step 3. Building on what works to create a new neurological loop. Now, this really is where we solidify the change, creating a new default mode for your brain. By consistently focusing on the miracle future and exceptions, we are actively recalibrating the RAS. The brain's filtering system begins to understand that solutions, strengths, and moments of success are the new priority. It starts to automatically scan your client's environment, not for problems, and for even more hopeful opportunities and evidence of progress. We ask the what's better question, starting each session with what's been better since we last met, strengthens this new neural pathway. It forces the brain to retrieve memories of success, making the connection between your client's intellectual goals in the PFC and their emotional experience in the limbic system stronger. We then collaboratively identify the client's next small actionable step, for example, asking, what would it take to get to a 4 on the scale? We then create a manageable task for the PFC. Achieving it provides a small dopamine hit, helping balance the creation of natural dopamine and also creating a positive feedback loop that makes the next step easier. So by using this solution-focused approach, we are not just talking about change, we are actively rewiring the brain. We leverage the ACC to flag new possibilities, use the PFC to build a concrete plan, and retrain the RAS to focus on the client's future they are creating rather than the problem they are leaving behind.
Integrating clinical hypnotherapy, aligning the subconscious mind.
Your primary role as the hypnotherapist is to align the client's subconscious programming with the conscious goals they've established in therapy. While their conscious mind wants the miracle future, their subconscious is still running the old addiction program. Your job is to help them install a new one. Number 1. Any hypnotherapist's job is to bypass their client's conscious, critical mind, the internal editor that generates doubt and resistance, with thoughts like, "This is too hard," or "I can't do this." Once this critical factor is relaxed, the client enters a focused state of attention where their subconscious mind becomes highly receptive to new positive suggestions. Number 2. While the client is in this relaxed state, have them mentally rehearse their desired future using future pacing. Guide them to vividly imagine living a day free from addiction. Make sure you use all the sensory details to make it as sensory rich as possible. Have them see themselves waking up refreshed, hear positive interactions with their family, feel the satisfaction of enjoying their work and hobbies. By having them experience the powerful emotions associated with this future, like pride, peace, and joy, within the hypnotic state, you are embedding it as a template, a new pattern of achievable reality in their subconscious. This creates a powerful pull towards their goals, reducing the need for constant conscious effort. Number 3, anchor positive resources. Next, help the client anchor feelings of strength and control. Have them recall an exception from their conscious therapy, a time they felt resourceful and successfully resisted an urge. In the hypnotic state, instruct them to intensify that feeling of strength and calm. As the feeling peaks, guide them to create a simple, discrete physical anchor, such as pressing their thumb and forefinger together. Instruct them that whenever they feel a craving or face a trigger, they can use this anchor to instantly access that state of resourcefulness, giving them the internal strength to overcome the urge. This combined approach creates a powerful feedback loop. The conscious therapy work identifies the destination, and your hypnotherapy work paves the road. The client's reticular activating system, or RAS, is recalibrated by both their conscious focus on what's better and their subconscious acceptance of a new, healthier identity. Each real-world success reinforces your hypnotic suggestions, making the neural pathways for recovery stronger and more automatic. This ensures the client's entire mind, conscious and subconscious, is working together toward the same goal. Other techniques, such as the playing card technique, hand swish, traffic light for urge surfing, memory card, timeline and resource-based regression, parts, tapping and anchoring, and the washing machine technique can be used in the hypnotherapy session. These can be found in the HHC Practitioner's Handbook, the toolkit for solution-focused change that is available for you to purchase from the HHC website or via the link in the resources section of this course.
Professional boundaries, safeguarding, and multidisciplinary working.
Working with clients facing addiction requires a clear, professional, and compassionate framework. Here is a list of do's and don'ts covering key areas. Disclaimer: this is general guidance and not a substitute for professional training, supervision, and adherence to the legal and ethical codes of your profession. Regarding payments upfront, you should be transparent and consistent. Have a clear written policy detailing your fees, what they cover, payment methods, and your cancellation policy. Discuss this in the first session so there are no ambiguities. You should take payment before or at the time of the session. This maintains a professional boundary and ensures the focus of the session remains on therapy, not finances. You should discuss potential financial barriers. If a client is struggling, explore options like reduced cost slots if you offer them, or signpost them to free local services. Regarding professional boundaries, you should clearly define the relationship Establish session times, length, and how you can be contacted, for example, through a professional line for emergencies only, not via personal mobile or social media. You should be mindful of self-disclosure. Only share personal information if it is brief, purposeful, and for the client's therapeutic benefit. The focus must always remain on them. You should maintain your professional role. You are their therapist or counselor, not their friend, sponsor, or rescuer. You should not over-identify or become emotionally entangled. It's vital to empathize without taking on the client's struggle as your own. Regular supervision is crucial for managing this. You should not work outside your competence. Be aware of the limits of your skills and refer clients to other specialists when necessary. Regarding safeguarding, you should explain confidentiality and its limits from the start. Clients must understand that you are legally and ethically required to break confidentiality if there is a serious risk of harm to themselves or others, especially children. You should be familiar with local safeguarding procedures. Know who to contact in your local area for adult and child safeguarding concerns. You should document everything meticulously. Keep detailed, factual, and objective records of any safeguarding concerns, the actions you took, and any consultations you had. You should not promise absolute secrecy. This is misleading and puts you in an impossible ethical position. You should not ignore warning signs. Take any disclosure of self-harm, suicidal thoughts, or intent to harm others seriously. You should not try to manage a safeguarding risk alone. Always follow established procedures, inform your supervisor, and contact the appropriate authorities. Regarding client welfare and safe cessation, you should always prioritize medical advice. Stress that you are not a medical professional. The first and most important step for any client wanting to stop using is to consult their GP or a specialist substance misuse service before working with a therapist. Ensure you have this in place. You should educate them on the specific dangers, inform them that stopping abruptly can be life-threatening due to the risk of seizures and delirium tremens. Medically supervised detoxification is essential for some substances. You should develop a comprehensive safety plan. This should include any medical interventions, sources of support, and strategies for managing cravings and high-risk situations. You should never advise a client that it is safe to stop using on their own. This constitutes giving medical advice and is incredibly dangerous. You should not underestimate withdrawal. While withdrawal from opioids or stimulants is not typically life-threatening in the same way as alcohol, it can be intensely physically and psychologically distressing, posing a high risk of relapse and self-harm. You should not support an unsafe detoxification plan. If a client is determined to stop without medical support, you must clearly state your professional concerns and document this thoroughly. Multidisciplinary working with external organizations. You should build a strong network of local contacts. Be aware of the services available in your local area, such as the NHS Substance Misuse Service, housing support, mental health services, and debt advice charities. You should encourage engagement with mutual aid groups. Suggest options like Alcoholics Anonymous, AA, Narcotics Anonymous, NA, Cocaine Anonymous, CA, and Smart Recovery, explaining that peer support can be a vital part of long-term recovery. You should work collaboratively with consent. With the client's explicit written permission, liaise with other professionals like GPs, social workers, or probation officers to ensure holistic wraparound care. You should not try to be a one-stop shop. Addiction is a complex issue that often requires a multi-agency approach. You should not force a particular type of support. Respect the client's autonomy. If they are resistant to AA, for example, explore other avenues like Smart Recovery or one-on-one support. You should not share information without consent unless a serious safeguarding concern overrides confidentiality.
Summary and close.
As we bring this session to a close, I want to thank you for your time and focused attention. Let's briefly summarize the journey we've been on together. We began by demystifying addiction, establishing that whether it's a chemical dependency on a substance or a behavioral compulsion like gambling, the underlying neuroscience is fundamentally the same. We saw how both hijack the brain's powerful reward system, creating a predictable and destructive cycle of dopamine seeking, tolerance, and withdrawal. But this wasn't just an academic exercise in understanding the problem. The true purpose of this CPD was to connect that knowledge directly to your practice. Now, when you ask a client the miracle question, you know you are deliberately disengaging their reactive, problem-saturated limbic system and activating their creative, resourceful prefrontal cortex. When you search for exceptions, you understand you are actively recalibrating their reticular activating system, training their brain's filter to start noticing hope and possibility instead of just problems. And when you, as a hypnotherapist, guide them into a future-paced scene, you know you are aligning their subconscious emotional drive with their conscious goals, creating a unified neurological purpose. At the beginning of this CPD, I spoke about the difference between knowing how to operate a car and having the confidence to drive it in a storm. The knowledge you've gained today is your advanced driver training. It provides you with a deep, grounded confidence that isn't based on just hoping a technique will work, but on knowing why it works. This understanding is what allows you to be that unshakable anchor for your client. When they are lost in the chaos of their addiction, your confidence in the process and in their innate ability to change becomes their lighthouse. You are no longer just applying scripts. You are a skilled and insightful navigator of the human mind, equipped to guide your clients through the storm and toward their own solutions. Trust in this process, trust in your clients' capacity for change, and above all, trust in your enhanced ability to facilitate that journey. Thank you for your time today. I'm John Lowson, and I wish you all the very best in your practice.
To complete this CPD on working with addiction, please proceed to the assessment quiz to complete your learning. This will then allow you to download your personalized 2-hour CPD certificate. You will also find a link to allow you to download your free PDF Practitioner's Handbook, Working with Addiction Clients. Should you require a printed version to be delivered, you will find a link to order on the resources page of this course. On behalf of HHC Training, I would like to thank you for purchasing this CPD learning package. If you do require any assistance again, you will find the details on the resources section of the course. Or you can email us at cpd@halifaxhypnotherapy.co.uk. Please note that Halifax Hypnotherapy is all one word. Thank you again. Enjoy the rest of your day.